All right. With that, I'd like to move on then to Mark Neumann, Editor-in-Chief with Nephrology News and Issues, who will provide us an update on payment and policy, in particular as it relates to the ESRD program update for 2017. Mark, thanks for your contributions today.
You're welcome. Thanks, Bruce, and thanks for inviting me to the WebEx. We're going to be covering a lot of material today, both in terms of what's occurring in January of this year. A lot of new policies are taking place and be coming into effect. And then we'll also cover, as Bruce mentioned, what's going on with the ACA ruling. Before I begin, though, I'd like to dedicate this talk, if I could, to Judith Carey. Many of you remember Judith, know Judith. She has been with CMS for many, many years, very involved in survey and certification. She's been a great fan of NN&I and has been a great resource for us. And on January 7th, she retired. So I think we're all in agreement we're going to miss her input and miss her involvement in the renal community, and we certainly hope that she enjoys that. So, Judith, thanks very much. So let's talk about some specific policies that are taking place, that have been part of legislation over the last 12 months and come into effect in January. This first one is about AKI, acute kidney injury care, that is now being allowed in outpatient dialysis clinics. And that's a big victory for the community. Many groups have been working on this for a number of years. There's a sense that these patients can be taken care of better in an outpatient facility. So and it's an interesting process how this all came about, but let's talk a little bit about what the new law actually says. And that is that these AKI patients can be treated in an outpatient dialysis facility. Reimbursement from CMS will, in essence, be very similar to hospital payments. In other words, there is not a limit, as we now have for typical outpatients, typical dialysis patients for 3 times a week. There is an unlimited number of treatments that can be provided based on what the nephrologist orders. So there's no restrictions on that. There are additional services that can be billed outside the composite rate. CMS recognizes that these patients have other issues that are not specific to dialysis, and they are willing to pay for those. So those can be billed separately. And interestingly enough, they're also allowing for facilities to use PD if it makes sense for the patient, and that has to be done in center. So there's some interesting applications for this. Most people feel this is going to be a good thing. It's going to be a good thing for patients, and we'll see. Ultimately, the test will be about outcomes. Will these patients actually do better under the care of a nephrology team? Another big story that's occurring this year is patients being allowed into Medicare Advantage plans. Currently, prior to this, if you were a patient, if you had ESRD and you were already in a Medicare Advantage plan, obviously you could stay in that. However, if you got ESRD and you wanted to go into a Medicare Advantage plan, it was not allowed. This new law allows that to take place. Is a big victory again for the provider community. They've been working on this for a number of years, and that's effective for 2017. The ESCO project. This has been going on for over a year now. However, CMS felt that they needed more applicants from the smaller provider, the so-called, the small dialysis organizations, the medium-sized. And they were concerned that with this demonstration, if we didn't have those included, it would really come down to whether the top 3 providers could make integrated care work. And we know they can do that. So it was important, I think, from CMS's perspective, that we also include small providers. So they reopened up the application process this past year, and we are waiting to hear which new providers have joined the demonstration. We were expecting to hear that at the end of this year. We're now hearing sometime in early January we will get that list. We have heard from various sources that U.S. Renal Care, certain Centers for Dialysis Care in Cleveland, Atlantic Dialysis have put in applications and are expected to be approved. We also heard that FMC has also put in additional sites as part of their demonstration. So we're expecting at least potentially at least another 7 or 8 or maybe even 10 more demonstration sites for this ESCO project. Currently there are 13 that have been approved. Every year, of course, we get a new prospective payment system rule and a new QIP, Quality Incentive Program rule, and this year, of course, is no different. The final rule was approved on November 2nd, and, of course, that all started January 1st. There's a slight increase in the bundled rate this year. This rate also, by the way, is what is applicable for those AKI patients that I mentioned earlier. There's a doubling of payment for home dialysis training. That is indeed a big victory for providers, particularly for those who train home hemodialysis patients. Training for those patients requires more time, more effort, and there's always been a sense that there should be more payment for those patients and the training for that. So that was a big victory. Just as an FYI, CMS is having an open door forum next week, January 17th, that will review all the changes and additions to the QIP, particularly the quality measures and the performance score for those measures. So to register, there is a website there. We can certainly flash it up at the end of the talk again. And CMS does this every year, which I think is important. They go through all the new changes and provide information on how to move forward with those. So that is coming up next week and is open to everybody, of course. The star ratings. This is, of course, has been a story for a couple of years now. The 5-star program is an effort to help patients better understand how to compare quality measures from one facility to another. Lots of controversy in the beginning. Providers complained that there weren't enough 4- and 5-star facilities. 5-star is the top that you can receive. So there have been some changes made. CMS had a refresh in October, and of course that meant, and that did mean that more centers that were 2- and 3-star are now 4- and 5-star clinics. So the provider community seems to be happy with the outcome. Recently I did an editorial because we received correspondence press releases from most of the providers saying, in fact, yes, we are number 1. So it's a little bit of a conflict. Everybody believes they are the best now based on their star ratings. But ultimately, I think the next step really for this system is to get patients to use it, because that's really the intent. The dialysis facility compare has been around for a long time. The star system is supposed to simplify that information and give patients a real barometer on where they should be treated. And yet there isn't a lot of effort being done in terms of educating patients and to let them know this resource is available. And that ultimately is what the intent of the program is. So I think that should be CMS's next step, is get the word out. And this is just a quick chart that shows you where those changes have taken place. So you can see where the original and the updated stars are, if you will. And you can see that there are certainly more 4- and 5-star clinics than there were previously. So that was the intent, and that certainly makes providers happy. And I think CMS overall is happy with the changes as well. Let's move on to the dialysis facility compare site. There are a number of new policy measures that have been incorporated in that. Again, this is information directed to patients to help them decide where they want to receive their dialysis. And one of the most important things, and I covered this last quarter as well, is that they're going to start looking at patient experience surveys. Many of the other organizations that have 5-star, other healthcare providers that use 5-star, such as nursing homes, home health, they use a lot of patient experience surveys to help other patients decide where they want to be treated. We have not done that much in ESRD. That has now become a bigger process or a more extended process in the QIP, and CMS feels that this is important for patients to see. How do other patients rate the care at a particular facility? It's very important, I think. So that has become part of dialysis facility compare. and I think that's an important step. Also, there's going to be some more information about bloodstream infections. Again, we know how dangerous they can be. A facility that does a better job of in essence, becoming infection-free if they can is an important step, and it's important for patients to know how these facilities are doing. So that's going to become part of DFC as well. And then lastly, there's a KTOV measurement for pediatric peritoneal dialysis. Certainly, the QIP and Dialysis Facility Compare wants to start paying more attention to pediatric care and pediatric units and how they are doing in terms of quality measures. And same thing goes with other modalities. We tend to think of, 90% of our patients are in treatment center, but certainly there should be quality measures that patients should look at in terms of how PD and home hemo patients are being cared for. So I think that's an important step as well. All right, let's move on to physician payments. Every year, of course, there is a new physician fee schedule that comes out from Medicare. And, of course, as we discussed last quarter, there is a new physician payment system in place. Let's talk specifically about the fee schedule. It's interesting because you see this cover from RPA News, which I highlighted last quarter. And in the most recent issue, they simply changed one word, which was going from the Medicare fee proposed rule to the final rule, which still presents, of course, challenges for nephrology. But most of it is pretty good news, actually. Nephrologists won't really see a change in their MCP and in other payments. But there are a couple of things that are taking place. One of them is looking at home dialysis CPT codes. So this, is, in essence, is what physicians get paid for their monthly capitated payments for home dialysis services. And it historically has always been less than if you are treating somebody in center. There's been some reports that suggest, well, maybe patients are not being moved to home dialysis because physicians don't get paid as much as if those patients were being treated in center. So what CMS wants to do is reevaluate those home CPT codes and determine if, in fact, they should be changed. The question that I think the renal community might have is if, in fact, they decide to put more of that money into home dialysis, will that money be taken from in-center? So I think that's an important discussion, and there's some reluctance, frankly, among the physicians, among nephrologists, the nephrology community about reevaluating these codes. The second thing that was very important this year was that CMS has been bundling billing codes for vascular access, interventional vascular access. They're trying to bundle codes that deal with certain procedures. And the original proposal, the proposed rule, had called for almost a 40% dip in the amount of money that was being dedicated to interventional procedures by doing this bundling. There was a lot of concern in the renal community about this. Some of that bundling still did take place, but the cuts were not as bad as feared. Some codes were increased, some were decreased and bundled, so the bottom line was that while there are some reductions in payment for these interventional codes, it's not as bad as the original proposed rule. So the renal community, I think, was very effective in getting the message out to CMS that some of these cuts were just too draconian and would jeopardize patient care. So that was successful in that regard. Okay, well, let's talk a little bit about MACRA, which in essence is this new physician payment system that we talked about earlier. This replaces an older form of payment that needed to go. This is a new system, and for those of you who are administrators and work in clinics, think of the QIP for physicians, because that's in essence what this is. It's pay for performance. Quality measures will be evaluated, and physicians will be paid based on how well they do. I mean, that's in essence what it's about. We're going to be hosting a webinar on this topic on February 23rd. I have some more information in a couple slides coming up, but it will in essence help to dissect how this new system works, and we hope you can join us for it. It's a free webinar, and we'll have that on February 23rd. But in essence, this is a brand new system for physicians. Everybody will be affected by it. And it's going to really, in essence, and here's some information on that webinar I mentioned, but it's really going to, in essence, push physicians into a paid-for-performance formula. And the better they do, and the more involved they are in integrated care systems, the more that they will be paid. So a lot of this will be covered at the webinar. We hope you can join us. Mark it down for your calendars, and registration is the registration site is currently live. So we hope we can join it we hope you can join us for that. And here's a couple of things, as I mentioned, that MACRA replaces. It eliminates the sustainable growth rate, which is a formula used to govern Medicare pay for physicians. This thing needed to go, as I mentioned earlier. It was very archaic. The new system will give physicians a slight payment increase through 2019, and they expect beneficiaries are going to save some money on this because it's a better system. Physicians will, or CMS rather, is starting to gather performance data now so that they will have, in essence, 2 years of data to start determining what payments will be. Again, very similar to the QIP, as you know, and there are two systems here that are available to physicians, merit-based payment incentive system and the advanced alternate payment models. And here's the timeline for MACRA. As we mentioned, released proposed rule in April, final rule published November 1st, and January of this year. First, in essence, performance year begins, and that's when they're going to start gathering quality data. Okay, I'm going to start moving faster through this because we're getting a little bit past our deadline. But this is probably the biggest story, certainly of the month, and in fact this week. And many of you have been reading about this. This regards how patients have been moved, not just in dialysis, but in healthcare in general, into third-party premium assistance, Affordable Care Act commercial healthcare plans. There's a lot of concern about this system. Of course, we don't know what's going to happen with Trump now in office. Ultimately, this system will be changed dramatically, probably in the next 12 months. But the bottom line here is that there's a lot of concern that providers have been pushing patients into these commercial plans, in essence, to be able to charge those plans more than they would be able to under Medicaid and Medicare. And this has been eased or made easier, frankly, by a premium assistance program run by the American Kidney Fund. And that program has been around for 20 years and has provided premium assistance to needy patients. But as these ACA plans have been available, providers have been looking at those as an opportunity to move patients out of Medicare and Medicaid and into these plans. And the AKF has been supporting that, in essence, by providing those premiums. So there's a lot of discussion here. There's a lot of information on these slides. And due to time, I'm not going to push that very hard. But the bottom line is tomorrow is a big day for this discussion. Tomorrow it is expected that a new CMS rule will, in fact, become effective. Will curtail a lot of these transactions, a lot of this steering, if you will, of patients into these plans. And there is currently a restraining order that several providers have put forth, and they're hoping to delay that final rule tomorrow. We'll see what happens. There's a strong expectation that the rule will go through, but it will change dramatically how the providers educate patients and look at ways, in essence, to determine if patients really should be in these commercial plans. And there's a lot of concern about it. There's a lot of concern about these commercial plans not offering the same benefits as Medicare and Medicaid plans do, and the question about the integrity of these decisions, whether providers are just looking for ways to increase the bottom line and charge healthcare plans more dollars. So I'm going to go through these slides very quickly, and then we have a poll question at the end. So as I mentioned, the insurers are very concerned about this kind of behavior, and again, not just in dialysis. Healthcare providers in general have been doing this. moving these patients into these private care plans. CMS put out a request for information to determine how much of a problem this is and found a lot of responses from people within the renal community, social workers, administrative personnel, who acknowledge that, yes, providers are aggressively counseling patients to move into these commercial plans. And the insurers are up in arms about it because it appears that providers have been sort of disguising this in terms of using the AKF fund to have these premiums covered. And there's a lot of concern about that because these insurers have the right through CMS to turn down a client or an application if, in fact, those funds are brought in from a third party. So a lot of concern about what that's about. I'm going to keep going to the next slide. The bottom line is, as we will see what happens tomorrow, is whether or not this final rule goes through, and that will have a major impact on these decisions. And, of course, as I mentioned, much of this can go away this year, depending on what Congress does with Obamacare. And I think the bottom line here is that it's the patient who loses out here. The patient who is looking for the best benefit package they can to have dialysis done properly with high quality and have the advantage or the potential to go into transplants. And that may be jeopardized by some of this behavior on the part of providers. And that's a real concern. We don't want the patients to be the last to be thought of. They should be the first. And so we'll have to see what happens tomorrow. Updates will be on our website. And I'll leave it at that. And I know we have one poll question. So, Brian, maybe you can help me out in terms of what I need to do next. Should I just advance to the next slide?
Yeah, if you can go ahead and advance to the next slide.
That is my, I'm sorry, my last slide would be the resources that you have for us. There's my email address if you need these slides or if you need further information. We do have 2 e-newses that come out each week that will keep you abreast of what's going on. And let's move ahead to that question then.
All right, so here's our first poll question for the day. If you can go ahead and fill it out. We need to stay on this slide. We'll probably stay on it for about 30 to 45 seconds, and then the results will show up here. So if you have a moment, please do that.
So the key question here for everybody is, should commercial health plans have the right to turn down applications from ESRD patients if the premiums are paid for via a third-party payer? I'm sorry, that got cut off, but like the American Kidney Fund's program. And I think that's key. Currently, CMS allows insurers to do that. We want to know what your view is on it.
Okay, Mark, we have final results now. Mark, any comment?
I'm going to forward. Whoops, I just forwarded the slide. I did not see the results, though. Here we go. The answer was 89% said no. Commercial health plans should not have the ability to turn down a application based on that alone. So that's an interesting observation. And it does send a message perhaps to CMS that there is some value in helping needy patients who need the funding to be able to take advantage of these health plans. And a program like what the AKF runs should be viable and should be done. Perhaps there are some rules that need to be changed for programs like that and how they are funded. But the message here is that a insurer should not be able to turn down a patient simply because their premium is funded by a third-party organization. So I'll leave it at that, and let's move on with the program. Thank you very much for your attention.
Mark, thanks so much. First of all, thanks again for your support of our Adopts Practice Monitor web conference updates. I really appreciate that. Also, I really appreciate your phenomenal review of all the updates in payment, performance policy, et cetera, which are really very, very complicated, but distilled and reviewed very, very clearly by you. So I really do appreciate that. Thanks, Mark.